Good afternoon, everyone. My name is Justice, and it is my sincere pleasure to welcome you to MHS's ADHD webinar series, Unmasking ADHD, Practical Strategies to Empower Youth and Adults. We are thrilled to have you here today and would like to take a moment to tell you a bit about MHS. For over 40 years, MHS has provided trusted, data-driven solutions across our core disciplines: clinical, education, talent development, and public safety. Science and research are the basis of MHS's roots and future innovations. With advanced tool sets, we help clients evaluate, track, and leverage human-centric data to help realize their full potential. MHS, through its collection of clinical assessments and solutions, specializes in aiding the identification and treatment of psychological disorders for improved patient outcomes at all stages of life. We also provide, through our education portfolio, expertise and resources required to help children and adolescents reach their full potential in and beyond the classroom. With our advanced suite of tools, team of experts, and robust data insights, we help clients provide comprehensive evaluations and uncover powerful insights. We will start this webinar with a presentation by Dr. Sam Goldstein titled ASD and ADHD, Understanding the Overlap, Untangling the Challenges. This session will break down how Autism Spectrum Disorder, ASD, and Attention Deficit Hyperactivity Disorder, ADHD, overlap and where they don't. He'll share stories from the field, real-life examples, and up-to-date research to help make sense of the confusion that can come from these diagnoses. Afterwards, we'll spend 2 to 3 minutes on the CE credit survey. And then we'll open the floor for a live Q&A with members of our MHS Research and Development team. Our main goal is to make sure you have an enjoyable and educational experience. Don't hesitate to ask questions anytime during the webinar, as our MHS staff is here to help. To ask a question, look at the Q&A icon at the top right-hand corner of your screen. When you click on this, a panel will appear at the side of your screen and you will find the Ask a Question button at the bottom of the window. Questions relating to the webinar content will be read aloud and answered after the presentation. Now, without further ado, it is my great pleasure to introduce you to Dr. Sam Goldstein. Dr. Sam Goldstein obtained his PhD in school psychology from the University of Utah and is licensed as a psychologist and certified school psychologist in Utah. He is also board certified as a pediatric neuropsychologist and listed in the Council for the National Register of Health Service Providers in Psychology. Dr. Goldstein is a fellow of the American Psychological Association and the National Academy of Neuropsychology. He is assistant clinical instructor at the University of Utah School of Medicine Department of Psychiatry. Dr. Goldstein has authored, co-edited, and co-authored over 50 clinical and trade publications, 6 textbook chapters, and nearly 36 peer-reviewed scientific articles, and 12 psychological and neuropsychological tests. He is editor-in-chief of the Journal of Attention Disorders. Since 1982, he has served as the clinical director of Neurology, Learning, and Behavior Center in Salt Lake City, Utah. We're glad to have you here today, Dr. Goldstein.
Good morning, or good afternoon, or maybe even good evening, depending where you happen to be in the world today. Thanks for joining this important yearly set of sessions in our efforts at MHS to keep everyone apprised of the current research in ADHD and related problems and the clinical application of that data. You know, for many years, there was a gigantic lag between when something was thought to be true in research and it actually was put into applied clinical practice. And we're seeing that time span shorter and shorter, particularly with the tools that MHS is developing. They live in the cloud. We make adjustments to them. And I think we're doing a better and better job of taking what we learn in applied science and using it in clinical practice. I'm Sam Goldstein. I'm coming to you from Salt Lake City, Utah, where I am the clinical director for the last 45 years of a clinic, a neurology clinic, in which we see about 800 children a year. About half have brain injuries, the other half have complex genetic problems. On the left is a QR code that'll take you to my website. And on that website, under resources, PowerPoints, this PowerPoint will be posted. On the right is my linker, and that'll take you to a bunch of different sites in which I have papers, in which I have overviews of tests, and of course, in which I have my music. My new album that's been out a couple of months, it's on all the platforms, is called Songs from the Fringes of My Mind. So, in this hour today, I'd like to lay some foundation about the relationship between autism and ADHD. Because on first blush, one would argue they're so different. And I want to try and help you understand why they are so different, but in many ways, they're also the same. And this has been an issue that's been debated. At one point, when you made a diagnosis of autism, you did not make a diagnosis of ADHD. Now you can. So it is not, at this point, a precise science. There's my website, my email, some social media. If you don't follow me on TikTok, if you're on TikTok, I have about 100,000 followers at Common Sense Science, and I rail on people who just don't know what they're talking about. And you're probably well aware of the studies that have demonstrated that at least 75% of information about conditions like autism and ADHD on TikTok are not correct, are erroneous, and yet so many people obtain their knowledge from sites like that. Okay, so let's get into this, and at the end we can take some questions. First, my disclosure. There's a couple of the books that I've co-authored and the tests, the ASRS. The adult ASRS will be out in the fall. We're very excited about it. And I can tell you, you now will have a valid and reliable way of determining autism. Again, questionnaires don't diagnose, but determining autism from any other condition. It's one thing to create a test that can separate normal from abnormal. It's another to create an instrument that can separate the kind of abnormality. And Jack and I together have done 3 instruments. The adult ASRS will be our 4th instrument together. So there's my disclosure. Why should we address this issue? Well, as I said, some symptoms overlap. Some behaviors overlap. Some impairments overlap. Some short-term outcomes are similar. And some treatments are equally effective for symptoms, not necessarily the whole disorder. We never treat a disorder. We treat symptoms and impairments the disorder causes, I think. We never eliminate the disorder itself in terms of developmental or mental health disorders. But let me give you just a quick historical overview of how this came about. Because if you say autism and ADHD are different and you start out with that premise, then you'll never identify overlapping symptoms. You'll stick to those symptoms that uniquely identify each of those conditions. But that isn't how the DSM has evolved. And the earliest diagnoses, before the 1960s, kids didn't really receive diagnoses. The DSM came out in 1952, and at that point, there was a tiny little section for children. And now it's a much bigger book, and there are a lot of diagnoses for children. We call it the DSM-5, but it's been revised when the American Psychiatric Association couldn't keep up with publishing another edition. So there's really been 8 editions, not just 5 editions. And who knows what's going to happen in the future as the DSM, in its diagnostic overview, moves closer and closer to the International Classification of Diseases, the ICD. And so at some point, I think the DSM will no longer be needed. So how does this come about? Well, if you remember Tom Achenbach and Achenbach's questionnaire, Achenbach talked about disruptive behaviors and non-disruptive behaviors. And when I first trained 45 years ago, or almost 50 years ago, I would do the bus test. I would ask myself, if I was on a bus, could I sit next to this kid? Because on a bus, children either disturb me or they worry me. It's pretty simple. And you've got internalizing problems and externalizing problems. In our efforts to create more homogeneity within the diagnosis, we've done 2 things. One, we made the diagnoses polythetic, like a Chinese restaurant menu, 2 from column A and 2 from column B. We said you don't need every symptom. And 2, we've taken the same symptom, because it does, in a statistical way, occur in a particular condition, we allow the same symptom to now fall in multiple conditions. Those two phenomena, I think more than anything else, are responsible for why children are now receiving multiple diagnoses. There's no doubt that mental health challenges have increased dramatically in the last 70 years in children. There's no doubt that post-COVID, particularly adolescents, have a much higher risk for depression and other related mental health problems. But putting that aside, we've also made it easier to make a diagnosis by softening the diagnostic criteria, by increasing awareness of the public, by offering financial incentives for certain diagnoses. In some states, actually in all states now, you can get some form of third-party reimbursement for ABA training if a child has autism. I have children I work with rare genetic disorders and brain injuries who are as much, if not more, in need of the ABA services, but health insurers have not been mandated to pay, and so they don't pay. So I think we address this issue with a foundational understanding of why these symptoms overlap and how we got where we are. And the question remains is where we're going. And if you want to apply for a research grant in a lot of organizations now, you have to provide genetics, you have to provide imaging. These behavioral diagnoses are not as homogeneic as we would like, or homogeneous as we would like. And the saying is, if you met one child with autism, you've met one child with autism. So there are some core issues that they share. We'll talk about those. And they're very different from the core issues of ADHD. It's the peripheral issues that have become part of the diagnostic symptomatology for the condition. And keep in mind, a symptom is a behavior, but by definition, it is part of the diagnostic protocol. So all symptoms are behaviors, but not all behaviors are symptoms. And as I said, most symptoms of ASD are not associated with ADHD. Most impairments in ASD are not associated with ADHD. And the two conditions seem to have very different risks and different outcome. I can tell you that when I first started and trained, which was in the early 70s, we did not make a diagnosis of autism unless the child had global developmental delay. It was very rare, even though low IQ or broad developmental delay was not part of the diagnostic protocol. It was rare. And today, 2/3 to 3/4 of kids diagnosed with autism have normal intelligence. So it's hard to look at outcome. You look at people in their 40s and 50s with a diagnosis of autism, and they may not be a good comparison to try and understand the outcome of children who are latency or adolescent age today. But differential diagnosis has always been an issue. What I will do for a child with autism is different than for ADHD. But what if a child with ADHD has some social pragmatic problems, doesn't rise to the point of autism, but they have some difficulty reading social cues? They would benefit from some instruction on socialization. And the other way around, there are a significant percentage of kids with autism, we'll look at that, who meet ADHD combined criteria. And many of them take stimulants, not for the autism, but for the ADHD symptoms. So our placement is varying, our treatment is varying, access to service is dramatically different. Imagine if a state legislature mandated that children with ADHD, once parents exhausted their out-of-pocket insurance, that children with ADHD could receive up to 20 hours a week of self-regulation training and guidance. And I will tell you, that will make a significant difference in the lives of those children, but the insurance carrier doesn't pay for it. They haven't been forced to, and the children don't receive those services. So is it really that difficult to tell if you use the DSM? Even though I'm a critic of the DSM in a lot of ways, I should tell you that I authored what is the major textbook on use of the DSM-5 with children. It's published by Springer. So when you look at these characteristic differences, which really have to do with taking perspective, reading social cues. I don't think children with autism lack empathy. I don't think they understand it. And you can guide them to care, and they get it, but I don't think they feel it. But they can engage in it. And that's what happens with a lot of people with autism now. We talk about coping or camouflage skills where what we see on the outside isn't really what the individual is thinking on the inside. So, in a simple way, it's not hard to look at the core problems. As I pointed out, it's the peripheral problems that are the bigger issue that we'll look at. So there's Susan Dickerson Mays. She and I went to school together. And looking at overlapping symptoms and ways of discriminating. And children with low and high functioning autism, again, that's IQ related, and combined ADHD, did not differ on maternal ratings of attention deficit, impulsivity, or hyperactivity. So you don't get a lot of difference if you just look at ADHD symptoms. And I'm going to show you our autism spectrum rating scale because in a census-based a sample that we've done twice now, we find the same thing. There we see PDD symptoms. So this is an older study. Are they an independent trait? And there's some argument that cross-trait correlations are weak and non-significant. And the results confirm that children with ADHD had high levels of PDD or social impairment. There's a study by Jim McCracken. These are a little older, and Mike Amon at UCLA looking at methylphenidate for children with PDD and finding that it works very effectively. Stimulants are performance enhancers. They enhance somebody's functioning regardless of the cause. We use it with brain injury. We use it with early onset geriatric dementia. They have a wide use. So differential may not be that difficult if you use the criteria completely and correctly. But the odds are, more often than not, you're going to see both. So let's take a step aside and define ADHD, and then we'll define autism. And then we'll look at kind of the overlap. We'll look at some data and talk about what does this mean for you and I? And what does it mean both clinically and in terms of eligibility, right? Because the way the IDEA is set up, the system in most states, you send in one category. You don't put kids in multiple categories. But clinically, if you diagnose ASD, you can diagnose ADHD. So out in the world, it's two diagnoses. In the school setting, it may be either other health impairment, ADHD, or autism. So I think ADHD is a biopsychosocial condition. I think the symptoms can have many causes. We see it very commonly in brain injury in kids with other genetic disorders like Fragile X. And I think it involves multiple parts of the brain that researchers have called the brain's braking system, from the back of the brain up to the cerebellum, up to the front of the brain. And I think it is primarily a neurotransmitter condition. Now, what do I mean by that? Well, conditions that respond to psychiatric medicines, and what do the psychiatric medicines do? They don't modify structure, they change balance of brain chemistry in the brain. And so conditions like ADHD, depression, bipolar disorder, schizophrenia, anxiety, they respond to psychiatric medicines. But conditions like autism, for example, learning disability, personality, they seem to have much more to do with how the physical brain is working, how the operating system, as it were, I was going to say hard drive, but how the operating system is working. And psychiatric medicines don't really work for them, despite the fact that Big Pharma has tried to find them. So what is ADHD? Well, people say it's inattention, hyperactivity, and impulsivity, but those can be caused by a lot of things. Look at the third bullet point there. And I think when people ask you, this is the response you should consider, that children with ADHD are repeat offenders. That is, they need more experiences in a similar situation before they can retrieve the memory of that situation in the moment to make a better choice for a better outcome. And typically, when you talk to them, they know what to do, but they have trouble consistently and predictably doing what they know. And in studies in which they're given sufficient time to learn to flush the toilet or put their backpack on the chair or whatever the case may be, you find that they do develop that behavior. And in some studies, however, it's 8 to 10 times as many trials. They also need more stimulation. That as interest in the task, stimulation of the stimulus itself, whatever they're doing, wanes, as it gets less, these kids stop participating. And finally, as they have to repeat things like 20 math problems, they satiate quicker, they lose focus. So if someone says, well, what really is ADHD? It's an immaturity that leads to a need for more stimulation, a tendency to lose focus with repetition, and more experiences to make behavior automatic, which is why they have so much trouble with driving. It takes them a lot longer to automatically see that red light or that stop sign that you and I see even when we're thinking of something else while we're driving. I think it's, again, a self-regulation problem. I think the comorbidity issue, that's a 2000 study, is even more at an issue now. We've added DMDD, disruptive mood dysregulation, and a significant percentage of those kids meet ADHD criteria. And the symptoms lead to an infinite number of consequences. And when I take a history, I divide a paper in half because history is short of following the child around for a week. History is the most valid means that we have to understand what's happening to the child, where they've been, where they are, and where they're going. And I divide a piece of paper in half. And as I listen and take the history, on one side, I'm writing symptoms, symptoms of any of the disorders that I'm concerned the child may experience. And if you're not comfortable doing it just on the fly, make checklists for yourself and just tick off the boxes as you go. On the right side, I write down consequences. So the symptom might be impulsivity, but the consequence is a long list of difficulty in which acting without thinking gets you into trouble. So here's self-regulation. What do I mean by self-regulation? And in the early 80s, Russ Barkley published the first textbook on ADHD. In the mid 80s, we published the second. And our approach was that ADHD was not a problem paying attention, but was a problem of impulse control, self-regulation, self-discipline. This came from the animal research. I was an animal researcher before I decided I liked kids better than rats. It was a very long time ago. The field, as you see now, has come around. And we recognize that when sufficiently stimulated, when the task is moving and quick, kids with ADHD pay attention just fine. They may make more mistakes. They may be less efficient, but they will play that video game longer. They just won't get as far in the game. And why is that? Because they don't have the automaticity necessary. So they don't inhibit, they don't delay. They have a hard time separating thought from feeling, separating experience from response. They have a difficult time considering an experience in the moment and changing perspective. They're kind of rigid, almost the way a kid with autism is. They don't consider alternatives very well. Whatever it is they choose is what they do. And when they choose it, they have a hard time with goal-directed behavior. They have a hard time tracking, is this working? They have a hard time changing a response when confronted with new data. They struggle to negotiate life, and I would add a word there, in an efficient automatic way. They're automatic, but they're inefficient. And they struggle to track cues. So what is a cue? It's something that happens, some sensory stimulus that tells you you need to do something different. All three of those scenarios I gave you in looking at what is ADHD require you pick up a cue and change your behavior. Think about driving. Green is go, red is stop. You drive without thinking, but you always have a set of behaviors should the light be green and you hear a siren. And some people are cueless, not clueless. Clueless means I don't know what to do. Cueless means I know what to do. I just didn't know now was the time to do it. And that's why typical reinforcement programs have failed with kids with ADHD because uh, they know what to do, but they struggle to do what they know. And you provide an incentive which drives them to be more focused in the hope that the behavior becomes automatic. But we typically cease the program because the kid's doing well long before the child is automatically and efficiently able to take what they've been doing and use it without the external reinforcer, without or the extrinsic reinforcer. And think about this issue of cues. This is a child you send upstairs, and I don't mean to pathologize or demonize or moralize the kid, but you send this child upstairs to get his or her shoes, and they come down without their shoes. And the room is a cue. The room should remind the child what they're doing there, but it doesn't. And in some ways, they're cueless. And they come down without the shoes, and you ask, well, what did I send you to get? And the child responds, my shoes. And you ask, well, why didn't you get them? And the child responds, I forgot. Didn't forget the task, forgot the cue, reminding them of the task. If something bangs on the wall behind you, you'll turn around and look. But you don't sit there thinking, if something bangs on the wall behind me, I need to look. The brain, this is maybe a revelation for some of you, doesn't multitask. The brain focuses on one thing at a time. But evolution and the complexity of our brain and the complexity of the sensory information all around us and has enabled us to keep track of hundreds of other possible things we should pay attention to. And if one of those things is cued, we shift our attention. And in some ways, the problem for children with ADHD, this immaturity, because it's not a disorder or a disease in that sense, it's an immaturity, that for these kids, the problem is either they're too easily cued to something else, or they miss the cue. It's one or the other, and oftentimes it's both. They're just not sensitive in an efficient way to cues. Now, there's a boy that I worked with who's now just about to enter college, and he had a terrible brain injury in an automobile accident, and they didn't think he would live, Thomas. And I do have permission to use his pictures. I'm dear friends with his family now. And he did live, and he looked very autistic and very hyperactive, wouldn't wear shoes. And his mother said one day he was in the kitchen and he picked up a marker and he started writing words on the wall. He wasn't speaking, mind you. And she brought him in, and that's in my playroom. He's writing things. He had me pull over a chair when he filled up the bottom of the board so he could write on the top of the board. And at one point he wrote elephant. And I thought, does he really know what he's writing? So I took out a whole bunch of animals and put them on the table. And I pointed to the word elephant on the board and said, give me the elephant. And he picked up the elephant. And this kid today does take Ritalin, but he's brilliant. He came from a very bright family. But at that moment in time, he looked as autistic as they come. So it gets us thinking, well, what percentage of children early on, say under the age of 2 or even 1, with significant brain injury, develop autistic symptoms? We know that a very high percentage develop ADHD symptoms. That's well known. But now there's research to show that maybe 1 out of 3 to 1 out of 4 children who are born with paraventricular hemorrhage, frontal hemorrhage, develop autistic behaviors. Should we call that autism? I don't. Why not? Because the DSM was created by studying groups of kids for which the goal was to rule out any other etiology in their presentation. So these diagnoses, ADHD or autism, if I'm doing a study and your child has a brain injury, they're out of the study. So we really don't know how well we can compare a child who develops autism after a brain injury with other children with autism. Because one of the things I didn't mention is what's the primary objective of a diagnosis? I talked about some different implications early on, but a diagnosis is really an assignment of risk. It allows me, if I make the diagnosis correctly, it allows me to compare you to a group of children like you and know what's happened to them over time and know what helped and know what didn't help. And I'm in a better position to help you. That was really the impetus for clinical diagnoses, and it's been lost in the shuffle because diagnoses are now used for billing codes. They're used to determine eligibility. They're really not used to make best practice intervention. So the DSM and the ICD are very similar. You see these three core problems. One of the things we recognized is in our epidemiologic studies is that social and communication skills really are one factor, and impaired behavior is two factors. I'll show you that. It's problems with self-regulation and odd or atypical behavior. So those of you that use the ADOS are already aware, and the ADOS algorithm was reformulated a number of years ago to combine social communication, but it's still a two-factor model. It still doesn't look at self-regulation. It's a major liability, I think, in the ADOS. And then this is the DSM view. It can't be during the course of a pervasive developmental disorder. That bottom criteria there, we don't use pervasive developmental disorder. It would say during the course of an autism spectrum disorder. I pulled an older description there, but it's pretty much the same description. And again, it was once referred to as a PDD. PDD was completely confusing because the most pervasive of developmental disorders, intellectual handicap or global developmental delay, was not in there. Rett's disorder was in there, childhood disintegrative disorder. So that's all gone away. There was a time when we were arguing that there should be subtypes of autism, autism with Fragile X, autism with mucopolysaccharidoses, because the incidence of autism is so much higher in kids with certain genetic conditions. And again, ASD is no longer referred to as a PDD, and we created social pragmatic communication disorder. They moved it into the language and developmental area, and it really is what Asperger's is all about. So we get into the weeds in these debates about one diagnosis or another. Imagine somewhere in the universe there is an intelligent species as advanced as we are, but Kraepelin, if you know who Emil Kraepelin was in the 1800s, in his efforts to categorize atypicalities of human behavior, supposing instead he said, we shouldn't label these things, we should define them by their impairments. And we shouldn't worry if it's autism or ADHD or social pragmatic communication disorder that's impeding this child's ability to self-regulate. We should focus on the self-regulation, which is what we do anyway. It'll be interesting to see how this system evolves, especially with AI's ability to process big data sets. So we're looking at some really big data sets in an effort to find out what behaviors really distinguish one condition from another. And should behaviors, there are some behaviors, Jack Naglieri and I have demonstrated on the ASRS, that are part of the autism diagnosis that really are not definitive for autism, say, versus ADHD, or definitive for autism even versus the general population. We did do something in creating 3 functional levels of autism. I think you've seen this before. It's pretty rare you make a diagnosis of autism with level 0, requiring no support. And what we're seeing over the past 40 years is a downward trend. We're seeing fewer level 2, fewer level 3, and lots more level 1. This is Leo Kanner. Leo Kanner was a psychiatrist. He wrote the first paper in 1943 in Nervous Child. He founded the Child Psychiatry Journal about these children that seemed socially aloof. And if you read Kanner's description, it sounds very much like the way we're describing autism today. It's really fascinating. Um, Again, he saw it as a social learning problem. He didn't see it as schizophrenia. He didn't see it as a behavior disorder, but a struggle of the brain. Some kids had language difficulty, some didn't, but a struggle of the brain to deal with the social world. And his ideas was that the reason these kids have a fascination with inanimate objects or purposeless repetitive movements um, is they're trying to make some sense of their world because they lack the ability to interpret the world in a social way. Leo was a fascinating man and a real pioneer. If you haven't read this article, it's from the Atlantic Monthly. It's 15 years old. I bet this man has passed away. Um, this is the first man diagnosed in the U.S., Don Triplett. At the time, he was 77, so if he was still alive today, he'd be 92. Diagnosed with autism. His parents were quite wealthy. He was a math genius, but couldn't do anything else. They took him to see Canner, and he was the first person diagnosed with autism in the United States. It's a fascinating story about his life because he had a very full life. He did live on a pension or a inheritance from his family, but it really challenges some of what we think and have thought about autism. It's really worth reading. Okay, so let's shift here. Now let's talk about autism. And before we look at the DSM criteria, let's look at what autism is as defined in a pure statistical way. So we can use exploratory factor analysis to see how one item predicts another. That's what exploratory factor analysis does. You have a hands-off approach, and you say, tell me how an affirmative response to item one might lead to an affirmative response to any other item on my list. But the items have to be valid. Do they measure what they say they measure? Can they discriminate autism from ADHD? And again, as I pointed out, the goal of the tool is to identify one difference from another, not difference from no difference. So if we look at the ASRS, it should differentiate adults and kids from the normal population. I just say adults there. And our new instrument does that. And clinical groups should look different. So let's just look at this for a moment, and then we'll come back and talk a little more about autism, although I think I've kind of set a foundation, and most of you are aware. There's a lot of data on this slide, but you'll notice on the y-axis, we have T-scores. 50 is average, that's 50th percentile. 60 is one standard deviation, that's 84th percentile. Higher is more impaired. What we see are teacher and parent reports for kids with autism, kids with all other clinical conditions except autism, depression, anxiety, ADHD, learning disabilities, and then the general population. And you can see what this tells you right out of the gate. The ASRS as a narrow spectrum tool is very good at separating autism from everything else, normal and clinical, which is why I think it's become so popular. But watch what happens when I partial out ADHD. Because if you look at this slide, you say, well, how is it possible that ADHD and autism overlap? You don't see anything. But if you take out ADHD from the clinical group flattens out, meaning the tool is even less effective at finding them. And the clinical group really looks like the normal group. But look at the ADHD group. So again, the other diagnostic groups suppress the ADHD data. When you pull out the ADHD data and let it present on its own, now look. So what you have is self-regulation. That's the fourth blip over from the left. And all the way at the end, attention. Self-regulation is a factor at an exploratory factor analyzed scale. We do not manipulate it. We do pick a cut point in which every symptom has some relationship to every other, but we pick a cut point in which we identify the most significant 6 or 8 behaviors. That's exploratory. The attention scale is a treatment scale. Now, those of you who use the ASRS know we designed this so you can use it to write IEPs or create treatment plans. It is a scale that's created with confirmatory factor analysis, meaning we're doing the statistic to confirm the group that we've already made. So what this tells us is if we only look at the behaviors on the self-regulation scale, and we only look at the behaviors on the attention scale, just those two, you can't tell whether a child has autism or ADHD. Now, look at the total score. More than a standard deviation different. That's the first blip. Look at social communication. A standard deviation and a half different. Look at unusual behavior, which the ADAS or the DSM calls repetitive restrictive behaviors. A standard deviation difference. So it's a funny thing because you could say, well, ADHD is autism without social communication and unusual behavior problems. That's silly to say that, but that's where they overlap. Now, why do they overlap? We don't really know. Could be that there are different genetic reasons why those behaviors are exhibited. Those behaviors don't necessarily have to have the same cause, right? Could be different causes. You could sneeze for a variety of reasons that are very different. But look at that overlap, and if you look at teachers, see the same thing. Teachers are a little more sensitive to the clinicals because they're trying to teach a class. And kids with depression or anxiety or learning disabilities or other mood disorders are going to stand out to some extent. But the same profile shows up. You need to understand that the best tools today, the tools Jack and I develop, the other MHS tools like the Children's Depression Inventory or the MASC, the anxiety scale, and of course the different Connor scales, they are all created with exploratory factor analysis. We don't tell the test what to do. The test tells us what we have. And then we can create confirmatory scales that group items together that logically seem to go together, that we demonstrate go together statistically to help us with intervention, so that we know if we intervene for one of these behaviors, these other behaviors that load with it are likely to improve as well. It gives you a way, let's say there are, on the attention scale, there are 8 behaviors. It gives you a way to decide, maybe I'll start with this one or that one. It's going to have a downstream effect on all of them. Why? Because statistically, they're closely related. So ADHD, how unspecified are they? The social problems of PDNOS, are clearly social issues that maybe are a little more present than normal kids. What about the social development of kids with autism? Well, it is a social learning problem, as far as I'm aware. These kids have a hard time taking people's perspective. One of the first research tools was the Sally Ann test, and I would hold up, it's for latency age kids. I hold up a pencil, or I hold up, let's do this one. I hold up a box of Good and Plenty, and I say, what's in the box? The child says Good and Plenty. I open the box, show them it's paper clips. I ask them if their friend came in the room, what would their friend say is in the box? Normal kids, normal as it were, will say Good and Plenty. A significant percentage of kids with autism will say paper clips. And when you ask them why, their answer is, well, that's what's in the box. So we call that theory of mind. I'm not going to argue the theory of mind is the cause or the only challenge for kids with ADHD, but it is a significant, for kids with autism, it is a significant contributor. Right out of the gate, children with autism are different. When they can see, they gravitate towards bright lights, towards other kinds of non-human stimuli. They don't look at faces. And they don't have an affinity to look at female faces, which babies will do just on an instinctual basis. And the muscles of their ears, Steve Porges has demonstrated, um, are set in the low frequency range of predators. So they are, in a sensory way, processing the world very different. And a tool that I have been using, that I've been involved with Ami Klen and Warren Jones have developed, is an eye tracking tool called Early Point. And I can tell you in 10 minutes in a 3-year-old whether they have a high probability that what we're seeing is autism versus, say, developmental delay. And at that 10 minutes, they're looking at an enhanced iPad that has cameras built into it that can look at up to 300 eye movements a second. And children with autism early on don't know where to look. And in that data, we find that under 6 months, they actually can look okay, and then it seems to go away, almost like when they get sensorially overloaded, almost like they're too sensitive, and then it goes away. So our sensory system, as we learn more and more about it and can measure it in more finite ways, may give us a greater insight into autism. And I think in the future, our diagnosis of autism will be technology, but our treatment will still require a collection of behavioral data and a way of analyzing that data and prioritizing that data to build a treatment plan. So tools like the ASRS are never going to go away. And I say that the ASRS doesn't diagnose autism, but it gives you a good start to making the diagnosis, and it definitely gives you a good start towards intervention. And just to kind of go through this, you're well aware, as I've mentioned, they don't imitate, they don't point, they don't have a differential preference for speech sounds, they have limited interest in the human face. And when you see before 24 months, they don't orient to their name, they don't attend to the human voice, they don't imitate very well, they don't show, they don't seem to have a lot of interest in other kids. And before 36 months, you begin to see some repetitive ritual behaviors. They don't demonstrate joint attention. What is joint attention? If we had time, I'd show you a short video of me playing a game with another child who has autism. And I look down at the game board, the child does not. And I look up at the child, he looks at me briefly and looks away. Joint attention is as we engage in the game, the child and I look down and look up. Think about when you give instructions, say on a whisk or a Cass or a woodcock. Some children, as you give the instruction, will look up at you and look back at the stimulus. And it's almost pathognomonic that kids with autism don't know when to look up. They'll look down the whole time, or they'll look away. Yeah, maybe ADHD plays a role, maybe anxiety plays a role. That's the differential diagnosis we clinicians have to make. And there's joint attention, which develops pretty early on. It's a foundation for more advanced social and communication skills. And what we're trying to do when we early on identify a child with autism, say with the Early Point tool, is change how parents do certain things. So when you read to a child, for example, we put them in our lap with their back against our chest, and we look at the book together, but we never make eye contact. And we guide parents to shift the child and begin shaping. Let's look at the book together. Let's look at each other together and make a comment and begin to shape joint attention, which we know can be done. And it does predict, if children can pick it up and begin to do it, it predicts better prognosis for language development. And pretend play is limited. It's usually repetitive themes. Young boy that I'm in the midst of working with as a consequence of a lawsuit. He was in a special program and they were using seclusionary timeout, but it ended up over a year's time with him spending more time in timeout than in the classroom. So clearly wasn't working. And he loves dinosaurs, and I can't get him to talk about anything but dinosaurs. even when I try and turn the conversation around to something else, it always comes back to dinosaurs. And his parents are wonderfully supportive of him. He's allowed to have one night a week where he can stay up as late as he wants and watch dinosaur movies. And then theory of mind, which I pointed out with the Sally Ann test. Kids with ADHD do have theory of mind. They can share joint attention. So this goes back a long time. In 1994, what is social information processing? Because kids with autism have trouble with social information processing. They come into a room and they can't, quote, read the room. They don't clearly understand what they're looking at. They don't see the relationship between people. They either intrude or they hold back, or they're just socially awkward. And the difference may be that a kid with ADHD knows what to do, but it is impulsive and inattentive and then doesn't do what he or she knows, which is kind of a differential for autism. And I want to show you this slide because this is what Celine Saunier and Celine is the author of The Island. We've been working on a test we call the CAB, the Comprehensive Autism Battery or Assessment Battery, in which we're trying to design tasks that directly apply themselves to developing intervention. Because every child with autism will have strengths and weaknesses in these 6 areas. And we're looking at the child's ability, for example, as a face becomes more clear, to identify an emotion, or to identify a verbal absurdity, or a visual absurdity. Children are on the beach, it's summertime, one child's wearing a snowsuit. Can that child identify what's absurd about that? So those 6 are what we've built our instrument around, the ability to attribute mental states to oneself and others. So you say to a child with autism, how do you feel when someone steps on your foot? And the child responds, I don't like it. And then you ask, well, how do you think your friend felt when you stepped on his foot? And the child responds, I don't know, I'm not him. Right? That inability to assign a personal state to others, to display appropriate emotion, I call it joint attention of emotion, the ability to plan and tend to relevant details. On the CAS, we find that children with ADHD have trouble with planning more than anything else, and children with autism have trouble on our attention tasks, knowing what to pay attention to. Understanding gaze, understanding how to work cooperatively, which again, joint attention and behavior, and then kind of putting together social information to come to a reasonable conclusion. You know, these kids have trouble if you, like on the old whisk, you give them a series of cards depicting some social situation. They have a hard time kind of figuring that out. So this is the current view of ASD in the ASRS. And if we had time, I'd show you the current view of ADHD in the Conners, which again is very similar to the DSM diagnostic criteria. You'll notice that self-regulation is not in the 2 to 5-year-old scale, and that will be true also when the next ASRS comes out next year. Why not? Well, try as we might, what we demonstrated is that most 2 to 5-year-olds have self-regulation problems, and you can't generate it. We couldn't generate a set of items that differentiated on a bell curve. It tended to skew. Lots of kids with that age range have self-regulation problems. And just to look at the validity, you know, we looked at it a number of different ways. You know, could ADHD and autism be differentiated from other conditions as well? It's one validity study looking at kids with ADHD just on the top exploratory factor analytic scales that you see there that I've showed you in the bigger graph. This is the teachers, very similar. And I've just shown you this. Again, just to reiterate, the overlap is on behaviors related to self-regulation, which is really the DSM criteria, and items related to attending to detail. So children with ADHD and ASD have similar behavioral challenges with behaviors associated with self-regulation and attention. but do they also have similar challenges in their ability to attend and self-regulate? Um, and again, you see a difference. They have trouble disengaging and shifting. And when we look at this data on the CAS, that's from our book on assessing intelligence and achievement. So there's if you guys know the CAS, it's 4 factors. It's planning, simultaneous or critical thinking, attention, and sequencing. The kids with ASD have trouble on attention because those tasks are not so much about paying attention, but knowing what to pay attention to. And I just jump to this slide, and you'll see there's the group with ADHD. They're low on planning. And the learning disabilities group, who have language-based reading difficulties, they're low on sequencing. I'm not arguing you're going to use the CAS to make a diagnosis. I just find that on a group basis, the differential is really quite interesting. And I'm going to jump ahead here for time basis. You can see the difference in the ASRS and CAS on the left for autism and on the right for ADHD. And Asperger, there's an article I wrote for the Autism Spectrum News in which I concluded it was one disorder of varying severity, and you can see that here with the ASRS. The dark line are kids with autism. The hashed line are kids with Asperger's. They almost parallel, almost exactly. They're just milder. And I'll just kind of jump ahead. You could see their profiles in terms of the KABC, the Woodcock-Johnson, where they have trouble. Processing speed shows up on the Woodcock-Johnson and on the WISC. And the ADHD group is clearly very different. So as you have time, I would encourage you to go back through these data. What do we know? Autism maybe represents something that children are born with and they lose, perhaps because of challenges to their sensory system very early in life. We know the earlier you identify, the more successful we are, for example, in reducing the number of minutes needed in special education placement. It is a measurable condition. It is distinct from normal behavior and development. The DSM-4, that should say TR and ICD, we think still requires revision because it still doesn't really encompass what we know statistically, not just our group, but others. What is autism? And we're still using the ADOS, in which that group has reanalyzed their normative data or their sample to create a current algorithm. I still think that current algorithm does not represent a 3-factor model. ADHD, on the other hand, is a 2-factor model, right? Inattention and then hyperactivity, impulsivity. So in exploratory factor and analytic studies, you don't separate hyperactivity from impulsivity. Sure, on a treatment scale, you will. Some kids are more impulsive, some kids are more hyperactive. But on a group basis, the two clearly overlap to a significant degree, such that autism's 3 factors, atypical behavior, problems with self-regulation, social communication problems. ADHD has 2 factors, attention and impulsivity, hyperactivity. They overlap on 1 factor, right? So there's 1 factor, that kind of self-regulation, attention factor, they overlap on. So, this is what I've tried to do. What is ADHD? What is autism? How conceptually are they similar or different? I've tried to show you what we believe is the largest epidemiological study and the neuropsychological data. These are the things I look at during assessment. I look at communication factors. I look at atypical behaviors. And I have a checklist that I go through. I look at all of these things. Yes, statistics are important, but training and experience and observing, especially if you have some kind of a checklist you fill out, like the cars, after you've interacted with the child, is critically important. And their cognitive functioning, I use the CAS, but I also use the Woodcock-Johnson. I like the Cattell-Horn model, and I think the CAS is really a neuropsychological measure. That's one of the drawings. I'll leave you with this. I asked Nate to draw a person, and he made a robot, which I thought was interesting. And I asked Nicholas, who also has autism, to draw a person, and he made Picasso Man. He didn't tell me that, but I immediately thought of Picasso when I looked at that. This is that little boy I showed you early on, a couple of years later. He did not have the course for kids with autism, as I mentioned. And this is a slide I show at the end of all my talks. This is Devon. He wrote this about 18 years ago to help everyone understand what it's like to have autism. He wanted to convey to people that he has a lot to offer the world, and you can read it yourself. It has a lot to offer the world, but people don't see it. And the metaphor he used were these beautiful rocks in a field that people came to visit, and one rock was ignored because it was just a plain, ordinary rock. And when everybody left and night fell, it glowed in the dark, and no one really appreciated it. I think we are slowly changing how we look at mental health problems, not just autism, not just ADHD, even personality, quote, disorders, unquote. I think and I hope that over the next 50 years, with the support of big data analysis, we'll be better at focusing on impairment, not necessarily better at focusing on labeling. The left is my linker, the right is my website. The PowerPoint's available on my website. There's my email. My TikTok's not on there. And I have a Substack article I send out every week you can subscribe to. I have almost 200 articles published online on Psychology Today on all kinds of topics you can take a look at. I always like to hear from people, both positive and negative. So it's been my pleasure to be here today. Thank you very much, and we'll take some questions.
So, Dr. Goldstein, our first question is, what are the challenges with assessment when someone has both ADHD and ASD?
Well, and that's really quite general. I mean, depends on the age of the child. Again, 2/3 of kids with autism meet ADHD combined criteria in most of the studies that look at that. So it's the rule rather than the exception. So if you think about administering an ADOS, a child who's much more active, has a harder time focusing in on the stimulus materials, it's going to be a bigger challenge to get them to participate, which might lead you to draw erroneous conclusions about their interest in interacting with the materials or their response to the birthday party or whatever you might be doing. With older kids, it's really not as much of a problem. Again, the challenge for kids with autism is creating rapport. A lot of the kids we see have to come in for 4 or 5 hours of testing. We try and start by creating some rapport, which is often difficult for kids with social learning problems. I typically start, like the child I tested this morning has those two conditions. I typically start with a discussion of something I know the child's interested in. In this case, this boy owns a horse. And so I started out by asking him about his horse. We talked about horses and then pretty easily transitioned into starting the testing.
Okay, great. Thank you so much. Our next question is, if those who lack abilities of self-regulation have more immaturity, how are we defining maturity?
Oh, so that's an interesting question. I define maturity as a comparison between how you exhibit a particular behavior or your knowledge of certain circumstances and what the typical or average kid might do. So sometimes on some of the tests, I generate scores and then go looking for age equivalent scores to try and see perhaps what is average for what this child's presenting. We do it on some tests like the VMI. You can do an age equivalent score. Sometimes on manualized instruments, I'll take a raw score and go back into the manual and look to see where that raw score might hit at the 50th percentile for a certain age range. I will do that with older people as well, because sometimes I'll have, mid, late adolescents, and I might be giving them a measure of comprehension or general knowledge or information, and they don't do very well because they're globally impaired. But I'd like to have some rough idea of the age equivalent, and I might go back into the manual and look to see what this particular performance equates to, if in fact it was average. So for me, maturity is really a discrepancy between how you behave and how it matches what I would expect for someone of your age.
Okay, that's great. Thank you so much. Our next question is, are there similarities and differences in the adult ASRS on the current scales that you can discuss?
I can't discuss them yet, but I can tell you that we validated the same three-factor model across all age ranges as we've had on the ASRS. So we feel strongly that autism throughout the lifespan in an exploratory factor analysis really consists of three kinds of behaviors or challenges related to self-regulation, social and communication, which is one factor, and atypical behavior.
Okay, thank you. Our next question is it common for children with brain injuries or TBIs to develop challenges with respective and repetitive behaviors and social skills that look similar to ASD? How do we determine if developmental disorder is at play or whether it's a brain injury?
Well, and the sample that I used in the presentation was a boy that I've followed now for almost 15 years. At the point of performance, you don't know. Especially with younger children, you don't have much pre-trauma history. Now, if you're seeing a 7 or an 8-year-old child who's had a fairly severe brain injury, and prior to that, you have school records, you have parent reports that they didn't exhibit, say, repetitive behaviors, that they didn't exhibit emotional dysregulation, it's fairly obvious that this behavior has an acute traumatic onset. And what I argue is that we have to be really careful in applying our ICD and DSM diagnoses, because the children that are studied were anyone with a brain injury or any other reason to behave that way other than just genetics is excluded from the study for things like ADHD or autism, because the incidence of autism and autistic-like behaviors is quite high in children who have frontal lobe paraventricular hemorrhages at birth or in their first year. And as I pointed out with the young man that I showed the example of, when I met him, had I not known his history, I wouldn't be able to tell if this was from a brain injury or from just genetics, because I really had very little to go on because he was so young when he had his brain injury, other than his parents said he seemed to be developing normally interpersonally. So sometimes you just have to watch over time. I just think, for me, a diagnosis is an assignment of risk. It allows me to compare the individual or the patient to a group. And I want to be careful that the etiology of that diagnosis matches for the person as to the group. And if it doesn't, then you have to just be careful about making assumptions about what's going to happen to a particular child if the cause of their ADHD is a brain injury, or if the cause of their ADHD is a serious psychological trauma, or if the cause of their autistic behaviors is significant lack of care or abuse. I just think you have to sit back and use your clinical judgment.
Yes, thank you so much. We have a question here that says, the crutch with Rating scales is the respondent's willingness and ability to identify and report on behaviors. I've often seen rating scales where reported behaviors do not match clinical observations or other data. Is there also differences between male and female presentation not fully covered in the presentation or data? Is this specified more in forthcoming ASRS? There's research that indicates female presentation in the ASRS is underreported.
So that's a lot of questions.
Yeah.
If we work backwards, remember the ASRS compares males to males and females to females. We try and have scales that look at validity. Is someone answering too quickly or inconsistently? We build that into all of our scales. So you can question the validity of the responses if you have some concerns about how the person took the instrument or whether they were overly defensive. Often we have differences between, if two parents fill it out, what they see. We have differences between self-report and observer report. We have differences between teacher and parent. We as human beings are very much responsive in how we behave and function to the environment around us. So assuming that a child with autism or ADHD is going to behave the same in every setting or is going to self-report exactly the way other people see it, it just isn't reality. I wish it was. It would make life easier. Again, it comes back to looking at the data and using your clinical judgment. Questionnaires don't diagnose, and trying to understand. And when I see differences among parents, I ask them about it. When I see differences among self or observer report, I've been piloting our adult ADHD instruments with young adults and their parents and find that they're very, very similar. So maybe by the time a child or adolescent reaches that threshold of adulthood, they're a little more willing or a little more able to analyze their behavior. With the ASRS child, we don't have a self-report because we found, try as we might, that they couldn't accurately report. They don't take the perspective of others, so it was very hard for them to report on their behavior and social interaction. Again, I think you have to look at each individual case. This is probably a topic of an hour-long webinar rather than a 3-minute answer, and I apologize.
Thank you so much for that. We have a question here that says, looking at early childhood, is there a difference in presentation between level 1 or level 2, such as intensity, or do all children generally present the same?
You have to look at the DSM to see. It's a narrative description. It isn't a statistical description. So it's not based on, if your behavior is 2 standard deviations above the mean, it's this, or if it's 3, it's that. It's an observation, a narrative, just like the GAF, the Global Assessment of Functioning, was prior to this, that was used for all psychiatric disorders. So just look at the 3 descriptors. It is really an arbitrary decision based on the clinician's judgment.
Thank you for that. What is the role of masking that you take into account when considering these diagnoses?
That too is a long response. Initially, we thought we'd call it masking or camouflage. I like to call it coping. We thought that females did it better than males. Now we know males do it as well. We have a coping scale on the ASRS, and I think we have, I don't want to overstate the data until I know for sure, but the more someone self-reports that they do a good job of, quote, masking, then the less pathology an observer will report. So it does absolutely play a role. And sometimes when you try and get at that role and you look at, there is a tool that tries to get at that that's not officially published, that tries to look at 3 different kinds of coping behaviors. If you go on my website and look at my longer webinars on autism, I go through that particular tool. So you just have to ask more questions about how well people cope. I mean, I'll ask some people and they'll say, oh yeah, I keep a list of what each of my coworkers likes to talk about so that I can check it and know what to talk to them about. And some people get very tired of this kind of coping and masking, because I'll leave you with this. If you look at my book with Bob Brooks, our tenacity book, it starts with the story of a boy I saw when he was 6 who had very high functioning intellectually autism. And he comes back to see me 35 years later. And he's been very successful in the eyes of society, but he's very stressed and very drained because he reports he has to spend his whole day, by his words, acting, pretending to be someone that he's not. And that's what these people will tell you, is that they spend inordinately a large amount of social energy doing that. And our efforts to fit them into what we think they should be is taking its toll, because we now see a greater incidence of depression and of suicidal thought and attempts among young and middle-aged adults with autism. I think our efforts to make them fit perhaps hasn't been the right path. That a better path is to help them figure out how they want to fit, not to fit the way we think they should. Bob Brooks and I have a new book. It'll be out in a month for adults with autism, built on that cognitive model I showed you. That's very much about figuring out who you are and who you want to be, rather than fitting into the world that everyone else has defined for you.
Okay, thank you so much. We have a question here. They are asking, so with the IQ measures, does this indicate our ASD kids will score much lower on KABC than other cognitive measures?
So Jack did a survey where we looked at all the different intelligence tests. And as I sit here, I don't have the data in front of me. I'm by far not an expert in the KABC. What I found is that kids with autism typically don't share that social contract that other kids have, where they want to show you what they know and what they can do. And typically they'll perform for you, but I tend to wait until kids are into their teens before I offer opinions about really what their level of critical thinking will be lifetime. They just don't carry that same motivation. You can see it on parts of the NEPC as well. And you can see it in, they're quicker to say they don't know. They maybe have more trouble at younger ages understanding the social pragmatics of certain kinds of questions. But specifically, whether they perform poorer on the KABC, I can't tell you.
Thank you again to Dr. Goldstein for giving us an informative presentation today. I'd also like to thank our attendees who joined us today. If we did not get to your questions in this webinar, please send us an email at marketing@mhs.com. We will forward your questions along to Dr. Goldstein or MHS staff. As a reminder, you'll receive a copy of this webinar recording in a few weeks. Thank you so much.